I'm Daniel Minty, a cognitive behavioral therapist, teacher, and writer. Carl Jung wrote of individuation, the process of taking one's predispositions and life experiences and integrating them into a mature personality. While something like this happens for each therapist on the road to maturity, there appear to be some common dimensions of this journey experienced by us all. My colleague and friend, Matthew May, and I recently spoke together about these dimensions. Matt is a psychiatrist in private practice in California and adjunct clinical faculty member at Stanford University's Department of Psychiatry and Behavioral Sciences. For some years, Matt and I have been co-leading weekly training groups for our colleagues at the Feeling Good Institute. Between us, we've trained hundreds of therapists and learned much from them about the dynamics of our personal and professional development. Matt and I invite you to sit in on our conversation now. So, welcome, Matt, to our conversation here this morning. Grateful to you for taking the time to talk with me about our experience of developing as psychotherapists. I noticed before I started that I was feeling somewhat anxious, and I realized I was grateful for that because it said to me, this topic is near and dear to my heart, and I would really like to create something with you that would have value for our colleagues and anyone else who might check it out. But I thought the starting point would be to just say, oh, I'm feeling maybe 10 or 15% anxious right now.
Hey, Daniel, I really like your I feel statement, and I'm right there with you. I care deeply about this topic and always run a little anxious anytime I'm speaking publicly. And I'm just feeling gratitude for you for making this happen and creating this space for this conversation.
We've been training therapists for some years now in our weekly groups. We've noticed that there are certain milestones or dimensions of our development as psychotherapists, and that some of these are skill-based. So we help colleagues to develop competency in delivering those 4 aspects of the team CBT model. Other dimensions aren't related to skills, but rather to our own personal experience. And one of those dimensions is seeing highly effective therapy. I wonder if you could speak for a bit to your experience of this dimension.
Yeah. One of my memories that I'll refer to and have talked about in at other times has been when I very first encountered David Burns, and he was volunteering and doing some teaching at Stanford on the open unit, the psychiatric unit there. And it wasn't a locked unit, but there were patients there who were really struggling deeply with depression, anxiety, frequently with eating disorders or with pain, and for most of the residents and folks working on that ward, they found it quite challenging to connect with the patients. The patients, I think, frequently were feeling pretty upset or angry with their experience on the hospital ward. And it was difficult to connect with them. And David was offering some training using these communication skills, the 5 secrets of effective communication. And it just blew my mind. It was such an inspirational encounter with him as he demonstrated how to connect with someone who's really angry or being critical or blaming or demanding. And he would use these communication skills, which just fit on one side of a sheet of paper in such a fluent way that you could just see how he could have someone who's really angry in one moment and upset with him, just really connect with them and build rapport very easily. And that really opened the door for me and gave me hope, and got me excited about doing this type of therapy. So that was one of my very first experiences, and I think it kind of lit the fire for me. It got me motivated and interested in learning that. And that's after that he welcomed me to join his training seminars, which I look back on now as really the fundamental and most powerful learning that I experienced in my career. So that would be one experience, is just to witness it, just to witness, very, very high quality therapy being practiced. What are your thoughts on that, Daniel?
Well, my experience of that is that you have regularly lit that fire for me. So in our work together over the years, I've seen you model highly effective therapy. And then the same thing has happened inside me, where I go, that's possible. I've just seen it. Now, maybe I can do that. I would love to do that. So maybe that fire is something that we pass on from one colleague or teacher to student and so forth. That's an image that we use in Zen Buddhist practice, that we light the fire within the heart of the student. And then the student has that to offer to others along the way.
Yeah, I like that metaphor a lot. I think it creates a sense of greater meaning and purpose in what we're doing. That it doesn't just stop here in this conversation, but it keeps spreading outward. And to be a part of that ripple effect is just a wonderful sense of belonging and purpose.
There's another dimension that we've talked about, which is the therapist's personal recovery experiences. So if we see a master therapist helping someone heal, that's one perspective on that. When we ourselves experience the healing, that's another. Could you speak to the role that personal recovery experiences play in our development as psychotherapists?
Yeah, I have a number of thoughts on that. I think that there's a real difference between witnessing and experiencing. I think if we're witnessing very high quality psychotherapy, let's say you go to one of David's seminars and you see a patient recover in a very brief period of time from panic or anxiety or depression, I think there's still part of us that can doubt what they just witnessed. Say, well, okay, maybe that was a fluke, or that was just that one person. Maybe that's not really generalizable. But to experience it firsthand, to have a radical change in your feeling state, that's just undeniable. And I think it causes for the therapist, they start to have faith and confidence in what they're doing at a level that allows them to communicate with their patients and inspire them more effectively. It's like to be absolutely certain there is a way out of depression, there is a way out of anxiety, and I know it because I've experienced it, allows the therapist to take on a role where they can, I think, be much more inspirational. And maybe in technical terms, they can offer the carrot in the invitation step in a far more realistic way. I think another thing that happens there is if the therapist has personally experienced and walked that path, they have the ability to connect and use their personal experience and really talk right on the same level with their patient. It's like, I've experienced that too. What you're describing, I've experienced that too, and it's awful. And my experience was like this, and then here's what cured me. And I'd love to offer that to you. I think that's a pretty powerful message coming from one's therapist.
So you're saying that seeing something out there that catches our attention and draws us to that experience is one perspective. Another would be an embodiment of that experience, where in our own bodies and minds, we experience recovery from anxiety or depression or phobias of some kind, and that you'd see that embodiment as being an important dimension of our growth as therapists and what it is that we can offer our patients.
Yeah, I think it helps both building a bond and a connection, like to have suffered in the same way as our patient, creates a sense of fellowship, and then also to have recovered from what they're suffering from provides a sense of hope.
Another dimension would be not experiencing healing because of the intervention of a therapist, but rather experiencing an individual recovery by utilizing the skills that we've been exposed to and developed. Could you speak a bit about how individual recovery plays a role in our development as psychotherapists?
Yeah. Thank you, Daniel. That's a great question. And I think it touches on this relapse model that when people are first experiencing recovery and therapy, it's with the therapist's help. The therapist is guiding them through a set of specific exercises that they're doing, and then they stumble upon the method or combination of methods that suddenly kind of lifts the depression or lifts the anxiety, and they experience it there with the therapist. And that's nice. It's nice to feel better in that moment. But there's a difference between feeling better and getting better. And getting better is when you've had the relapse outside of the therapy session, and you've gone right back into that state of depression or anxiety that had been so upsetting, and you remember to use the tools. You remember to take out, say, the daily mood log or a cost-benefit analysis, or do a positive reframing exercise, and you realize my therapist isn't magic. I don't need to be in their proximity in order to recover. It's really the methods that's where the power is, and the power is within me, right? The patient, to do this, and I can do it on my own. And I think that goes a long way towards eliminating the anxiety that people have when they try to sustain a recovery, which we can't. It's hard to really sustain a recovery. We all drift in and out of enlightenment. And the idea is just to not be afraid of it, knowing that we have the tools if we do relapse to get out of that relapse. And that just, oh gosh, that's such a relief. Just knowing that I don't have to wait until my next therapy session. I can recover right now.
So finding that within ourselves we have that power would be an important milestone in our personal and professional development. How would we facilitate that individual recovery in a patient that we're working with?
I think to go through the relapse model very carefully, where we're informing them that relapse is just a part of this experience, that during this lifetime at least, we never achieve a permanent state of recovery or enlightenment or whatever you'd like to call it, but instead we drift in and out of enlightenment. And just to be aware of that is useful. Daniel, you've probably had the experience of patients coming to you with the same problem that they've struggled with for years, and they're convinced that their therapy in the past just didn't work for them because of the relapse they're experiencing now. But then you ask them, well, what worked for you in the past? And oftentimes they will say, oh, I did exposure and response prevention and my symptoms went away. And then if you know that, then you also know that if they were to do exposure and response prevention now, that their symptoms would go away again. And you don't have to reinvent the wheel, just as their symptoms will always be the same when they have a relapse. The cure, the effective methodology will always be the same for them throughout the course of their life. And so part of it is just to be aware that relapse is inevitable, that we can't forget the negative way of thinking or behaving any more than we could forget the first language that we learned. That we'll drift back into speaking that language of negative thoughts again. And then the other awareness is that when that occurs, we won't think it's a relapse. It'll just seem as if we are really hopeless, and why didn't we realize it before? Our negative thoughts are hypnotic, and will induce this sense of, yeah, this is just true about me. I am worthless. I am defective. I am hopeless. And bad things are going to happen to me, and there's nothing I can do, or what have you. And it won't seem like, oh yeah, that's just a relapse. No big deal. I'll just do the daily mood log. And so we have to explain to our patients that they must pre-commit to taking out the tools, even when they're certain there's no point in doing so. So that would be the next piece of information or way of preparing people for relapse. And then you can also do things like, can we have a relapse now? I'll ask my patients, when do you think I would want you to have a relapse? And the answer is as soon as possible, because the sooner they have a relapse, the more fresh in their mind that recovery experience is and how they got there, so that they'll be more capable of recreating it for themselves.
Our patients often relapse, and what you've described seems like an excellent structure to help them address that situation. Do therapists relapse as well to earlier phases of their development or places of lesser skill?
Inevitably, yes. Therapists are people too. And so, and as such, they will also have these relapses. They'll also experience, a sudden worsening of their mood, or a sudden reduction in their ability to empathize or set an agenda. And I think what that means is there's like a garden to be tended here, or a sword to be sharpened. So a degree of work as therapists that we need to continue to be doing. And for therapists too, I think relapse can be a bit mysterious, and we may not even know that that's occurring, or the nature of it when it is occurring. And that's another reason why using testing with our patients is so important, because our patients will certainly detect when we've relapsed and forgotten to use some skills, or that we may have once been very proficient with.
So therapist relapse comes with the territory when we're talking about development as therapists. It's not a straight line from a lower level of skill to a higher level of skill. It's more a process of encountering our own inclinations and thought patterns and belief systems again and again and again. In that way, could we predict the nature of a therapist's relapse?
Yeah, I think we're all prone to certain types of thinking and behaviors as therapists. And so when an individual therapist experiences a relapse, it is quite predictable what type of relapse that will be. If your tendency as a therapist, for example, were to be a little bit anxious about, holding your patients accountable, let's say, then it's very likely that even if you have developed excellent skills at expressing your feelings or concerns or worries for them, if the patient's continuing some behavior that's risky to them, that when you relapse, you'll be back in a state of avoiding those feelings, avoiding talking about the problem that you're seeing with the patient. Or if you're maybe like too forceful or like swoop in to kind of help or offer advice or something like that, if that's the thing that is hard for you as a therapist, that's where you'll go when you start to relapse. It'll be right back to the same type of interpersonal errors.
Some of my patients tell me that though they've set an intention to parent their children differently than they were parented, when they get stressed and can't be as intentional in their parenting as they would want to be, they find themselves saying the things that their parents said to them that were not helpful, or behaving in ways that were not helping them develop when they were children. Is there a parallel here in terms of what would happen to therapists when they're stressed or frustrated or feeling confused with a patient?
Boy, I'm glad I'm not the only parent who experiences that. Yeah, exactly. I think that's an excellent example of a relapse, that parents go through those relapses too. Even if they're very determined, they realize, oh man, it just doesn't help to, yell or be critical or something like that. And in fact, it hurts horribly, and they've experienced that hurt themselves. That when stressed out, that's exactly the language that comes out. And I think expecting that and knowing that that's the case is a bit of a relief. And it also gives us some insights into how to get out of relapses.
I know that when we relapse as therapists, that same negative emotion comes up, that we'll feel frustrated, hopeless, maybe slip into blaming ourselves for not having more skill, or blaming our patients for not being, quotes, better patients, close quotes. I wonder what would be some alternatives when we realize that we ourselves are in relapse as therapists.
Yeah, that's a great question, Daniel. My sense is that when we relapse with our patients, that we are causing the resistance. So if you can even say we're forcing our patients to resist us when we have this idea that they must recover, or that we need to change them, or we need to help them. And it's an alternative might be to see this as really the patient is the one with the power and who will be making the decisions. And our stance would be one best described as something like open hands, is that we'd be delighted to be with them right now, just the way they're currently experiencing reality, and we're also willing to go with them to a different place. And it's kind of both seem like great options to us, just to connect with them and listen and empathize and understand their experience, or to be working towards some change and some other experience for them, some improvement in mood or relationships.
I've been teaching an alliance resistance class with our colleague Heather Clegg, and we've been looking at the role that curiosity can play in such moments. That if instead of trying to force things or create something that isn't in the picture currently, we can stop and invite ourselves and our patients to be curious about what's happening in our relationship with each other, in the process that the patient is experiencing. Can you talk a bit about your perception of the role of curiosity in the development of a psychotherapist?
Yeah, thank you, Daniel. I think that is just such a wonderful quality in a therapist, and Heather exhibits that, and you do as well so beautifully. And to get curious in those moments of failure allows us to turn those failures into success. And so one way of thinking about it is when we're failing a patient, we're butting heads with them rather than collaborating. There's an opportunity there. It feels terrible, but there's an opportunity for recovery in that moment and for mutual learning and growth, both for the therapist to get out of their relapse and also for the patient to learn about what happens for them and how can they get out of their relapse interpersonally. And I think if the conversation never occurs, if we don't get curious about what's happening or what's going on between us right now, using methods like changing the focus or the interpersonal downward arrow, then it's just we've suffered that without taking from it what it has to offer.
My first supervisor out of graduate school had been working in rural mental health for about a quarter of a century. And he told me the story of driving through the Columbia River Gorge there between Oregon and Washington and picking up a young hitchhiker. And the hitchhiker started asking Tim, "What do you do?" And Tim said, "Well, I'm a psychiatrist. I teach at the university and I consult." And the young man said, "If you could grant one thing to your patients, what would that be?" And Tim thought for a mile or so there on I-84. And his answer was curiosity. And when he told me that story, so many pieces clicked into place for me. That one way we become anxious or depressed or addicted or engaged in unhappy kinds of connections with each other is that we're no longer curious. We already know how this is going to go. We know what the possibilities are. And I thought it was quite brilliant of Tim to put his finger on that particular human quality. There's another that has emerged for me since that time, which is acceptance. I used to distinguish between self-acceptance and other acceptance. And then I realized it's the same act. If we move into acceptance, we are accepting all beings in that moment, if it's true acceptance. I wonder if you could speak to the role that acceptance plays in our development as psychotherapists.
Oh, I like that question a lot, Daniel. And maybe first I'll just acknowledge Tim's wisdom there, that to get curious is a good first step out of anxiety, depression, addiction. And then for therapists too, to be curious about what's really happening in the minds of their patients and their experience. I think that relates closely to the testing component, the T in team, is to not assume that we understand or know what our patients' experiences are, but to use science to get at it, and to then at that point our patients become our best teachers. And so I think I would wish that for my students too. If there's one thing that you could add to your repertoire, if you don't already do it, is to use some psychometric testing, and to get feedback using forms like the evaluation of therapy form, and then process what you see there with your patients every time you meet with them. And you'll be on a fast track to learning and growth. And as far as acceptance is concerned, absolutely. I think we could talk about should statements there, perhaps, that when we're suffering, it's typically because we're demanding something different than what the universe is providing. We're demanding that we be better, or that other person be better, or just the universe be better. And I think that demand creates a tremendous portion of our suffering. And that if we can instead accept what we're experiencing and allow it and let it in, that leads to relief on a lot of different dimensions. For example, if we're struggling with a therapy with a patient, it's often because we're not accepting them. We're not accepting what they're coming in the room with, in terms, let's say, of their resistance, what we might call resistance to change. And I've had the experience personally over and over again of feeling like, gosh, this person really should change. This person, like, they're miserable, they're feeling, terrible personally, and their relationships are suffering. They really should change. And that creates a huge problem. But if I instead try to understand why they shouldn't change, why it's important and beautiful that they remain exactly as they are, and we start to list all the reasons, all the advantages of their current way of thinking and feeling, and all of the good things that those thoughts and feelings say about them, then my need for them to change starts to go down in proportion to their sense of readiness to change. And I think that's part of the beauty of the agenda setting component of the team model, is that it gets us on the same page with our patients without our needing to change them or fix them or give advice or make decisions for them. But instead it empowers them as we become more connected and understanding of why they should be exactly who they are.
I think I'm hearing you say that a dimension of acceptance would be acceptance of limits, or of current limits, that we have current limits to our skills, and that our patients would have current limits to what they're currently able and willing to bring forward.
Yeah, right. The idea that it's not our limits or errors or shortcomings that are the problem. It's demanding that we not have them.
I know myself, it's a huge relief to acknowledge to myself and to my patients my limits. When I'm willing to do that, I can settle back into my own body, mind, here and now, and acknowledge what I'm capable of doing, what help I'm capable of offering, and where that capacity ends. I've found that my willingness to do that is oftentimes a real turning point in a therapy where there's been an undercurrent of a patient looking to me to recover for them or looking to me to self-accept them.
I like that a lot. Yeah. Yeah, my sense is that if we are vulnerable with our patients and open and sharing with them what our limitations are and how we're experiencing our interaction with them, and we do that in a respectful and admiring way, that's often the turning point, as you said. That's the moment that they see us as real human beings and see themselves as real human beings. Maybe that's in part it's a modeling that's occurring. We're modeling for them uh, how we can accept ourselves, our feelings, our experiences, and others as well.
I'm somewhat sadly acknowledging a limit, which is our time is almost up.
Yeah.
I wonder, before we say goodbye for today, if there's anything you'd like to add about your experience of how it is that we develop as psychotherapists.
Well, as we were discussing before we started to record, um, this is a huge topic, and it's one that I think is very important to both of us. And I'd love to continue here some other time with you, just to continue this discussion if there's an interest in your audience for more. But this is feeling like a good place to wrap up for right now.
Well, that sounds wonderful to me. Would love to take this topic up with you again sometime. And would also just want to express my deep gratitude to you for passing the fire along to me and helping me pass that fire along to others. I feel like I'm in a wonderful chain of family, we could say, or just human development. These skills that we cultivate within ourselves and support our colleagues cultivating, I think are the skills that the planet desperately needs these days. And I'm very grateful to your being a great light to me and so many others along this path.
Well, thank you, Daniel. It's just been such an honor and privilege teaching side by side with you and doing these psychotherapy training seminars that we do. And couldn't imagine a more brilliant and astute and wise partner in that than you. So thank you so much for including me and getting me on your podcast. I hope it's a tremendous success, and I look forward to seeing you on Thursday.
I'm looking forward to that already, as I do each week. Our time together with our team family on Thursdays has become one of the high points of my week. And you were instrumental in creating that family. So thanks to you for that.
All righty. Well, I'm all aglow now, Daniel. Thank you so much.
Thank you for sitting in with Matt and me. We hope you've enjoyed our conversation. If you did, consider subscribing to this channel. If you're a team therapist certified at level 3 or above, Matt and I welcome you to join one of our Thursday training groups. All therapists, and lay people as well, are welcome at my affordable weekly training and consultation program, All Things CBT.